we're just here to have a very, very general discussion about the process of palpation and treatment. So we've talked about assessment and the idea that what you're looking for is you're looking for motion loss or motion dysfunction that crosses a threshold that becomes interesting, and that you're not trying to remember every little movement, you're just trying to remember the bigger problems, right? A bigger problem is more likely than not to create a bigger problem or a bigger difference between expected motion or visible motion in a comparable structure on the other side of the body versus what you found. There's a large difference. So when you notice that large difference, you are then able to start to piece the picture together. And then we also talk about the concept that the more detailed your thought is, the harder it is to remember. So we can talk about the concept of cognitive load, like a high cognitive load. You're thinking too much to maybe pay attention. You're too much up here, not enough in your hands, or not enough paying attention, not necessarily in your hands. Because then we can talk about the concept of multisensory integration and using your eyes. So keep your eyes on the prize, right? Or keep your hands and your eyes on the prize is the way that I've said it before. So using hands and eyes, or using physical contact and visual contact, in whatever way you would like to term that. But when we're actually working, it's very common in osteopathic manual therapy, and not exclusively, but very common, that whatever structure you're attempting to mobilize or move or treat, you're going to be palpating. So a somewhat common movement is going to be something like, some people term a leg rotation, and you can term this different things. But we come through here, and oftentimes because people like to use long leverage, and they're going to say that they're addressing the innominate, and we've talked about the concept that the innominate and the sacrum don't move very much in relation to one another, especially in adults, maybe in kids, but not in adults. So some people will use this, and their intention will be to move one side of the pelvis or an innominate bone, so the fused ischium, ilium, and pubis. They'll try to move that in relation to the sacrum. So you'll see this, you'll see them talk about this. When you actually try to identify where their hand is, what they may be looking more at in an inferred sense is actually this side, or the leverage from this leg, kind of tipping the whole pelvis, even mildly backwards, to really try to create lumbar flexion. So what they say and what they do may not necessarily be the same, but something occurs. Right, so the hand goes underneath in the general lumbar region. Sometimes people will tell you maybe have your fingertips on the sacrum, and then the innominate or the pelvis will be in the rest of your hand. You can aim this at the lumbar column, so you have your fingertips in the region of the spinous processes, and then you go ahead and you use leverage. The point here is to talk about what's happening when you're doing this, or what might be happening, or what might be beneficial to do as far as how you pay attention. So as I go and I identify the spinous processes with my fingertips, and then I bring the leg up to use for leverage, what I'm doing is I'm going to, now my eyes aren't very helpful, and this is why we talk about patient positioning, and preferably the structure that you're working on should be visible, right? But I start to move through here, right, and I'm looking. Right? I'm looking in the general region, not specifically because I can't see the lumbar column, I can't see what I'm working on. But what I'm doing is I'm trying to identify motion. What do I feel happening on my hand? What's my expectation? So in the early stages of learning, we need to give you some concept of what you should expect. Essentially, as I bring the knee towards the chest, I should feel the bones basically fall back towards the table. Right? I should feel that happen. If I don't feel that happen, if the bones don't fall towards the table, then I'm not getting the expected results. So what I'm identifying is the difference between what is expected and what's occurring. When I do that initially, cognitively, the problem is that I don't necessarily feel it, right? So we talk about top-down processing versus bottom-up processing. So the initial lesson is, I tell you, as you bring the knee towards the chest, the spine should fall to the table. And you're like, you sit there, you go in, you have a really hard time with the initial dance steps, the motor learning, and you're like, okay, push the leg across, put the hand here, blah, 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 blah. And that's why we talk about the optimal theory of motor learning and having an external focus of attention, right? What I would aim to coach, aim to teach is bring the leg up. As you bring the leg up, bones should fall, or the spine should fall. right? So we try to keep it a little bit more cognitively simple. And you'll notice as I'm talking, I'm not consistently moving, right? One of the challenges becomes that to pay attention to what you are feeling and what you're seeing, if you have to talk and explain, the cognitive load goes up. So you're able to do things that are cognitively taxing with another task, so essentially quote-unquote multitasking, which some people believe in, some people don't. If one task is very, very, very highly practiced or very highly skilled, or essentially very low cognitive load, so as I'm talking and trying to explain and looking for words to help you understand this, I'm probably going to stop at some point. Also, there's habits that I have, or that many people will have, as far as hand gestures and the way that they express themselves. But to move back to this, when you're actually working, what you're looking for is the difference in motion. So as I do this, I have an expectation, bones should fall. When bones don't fall, when the spine doesn't go towards the table, when you don't get lumbar flexion, I've noted the difference. I've noted the difference between expectation and reality. To do that, I don't think about it. I perform the motion, and in a very, very simple way, right, in a very almost binary way, I'll say yes or no, right? Expected movement or not expected movement. So to maybe try to tie this up in a slightly different way, to say that even, say with a straight leg raise, I expect free motion, right? I expect it to go up. When it's not free motion to approximately 90 degrees, because I've cognitively learned that beforehand, and then over time, so that's the explicit learning portion, and over time, implicitly, I understand that a stiff leg is one that goes to here. A relatively good leg will go up to here. It doesn't have to go to 90 degrees, but this is a fairly mobile leg. So we have all these kind of learning processes intertwining. But what we want to do is that concept of having a motion threshold when we're treating. If we identify a motion problem or a motion dysfunction, the structure doesn't do what it's supposed to do, then what we're doing as we're treating is we're using multisensory integration. So you keep your hands and eyes on the prize. So you're using your eyes and your hands, you're using the motion, and when you're doing that, you're not thinking heavily from the top about what is it doing. You're not thinking about degrees, you're not thinking about complicated things. What you're trying to do is, with the treatment methodology that you choose, is you're trying to identify, is the difference between expectation and reality the same, or is it getting closer, right? So is it becoming freer? You keep the question, or the essential question, fairly simple. It doesn't work like this inside your own head. What it is no movement, free, good. Right? That's essentially a verbal description of what's probably happening. To look at it, to see what it looks like, would be something more like this. And saying this makes it very difficult. I can't explain it as I'm doing it. Again, I have an expectation, this works fine, but as I go over here, there's a lack of freedom, so I start to work through that. And I work through it, and I'm asking the question, I'm just looking for the freedom. And once I have the freedom, right, every motion is an assessment, every motion is a treatment. Once I have the freedom that I'm looking for, I can move on. So again, just that concept of minimizing the cognitive load. Don't do most of the work up here when you're treating. Do most of the work down with the patient or with your senses. So it's more of a bottom-up approach. So senses first, and then you can think about it after. Also, tying this in with what I've spoken about before with respect to assessment, is don't think complicated thoughts, or don't think about little stuff, think about big stuff.